Hello everyone. Previously, we have conducted so many case discussions on thyroid, but in this video, we will mainly learn about the examination of a thyroid swelling with the live patient demonstration. Okay, so at the end of detailed history taking in any thyroid case, you should be able to come to three things. First thing, anatomically, whether it's a thyroid swelling or not. Second thing, physiological, whether the patient is in hyperthyroid state, hypothyroid state or euthyroid state. Third thing is the pathological state, whether the swelling is because of some congenital thing or some infection or inflammation or because of some benign swelling, malignant or some idiopathy. This much you should be able to conclude at the end of the history. After which you proceed for examination. Please focus here. This is a very important and invariably kept case for both undergraduate and postgraduate examination in surgery. And also, it's a very important case from clinical point also. It comes in surgery, medicine, OBG, pediatrics, in all the branches. So, it's very pertinent to know in and out a detailed examination of thyroid swellings. So, Dr. Uda, how do we start the examination of any thyroid swelling?
So, any examination, first you should ask for 4 things. That is, you should explain the procedure to the patient. Inform consent, what we are going to do. And you have a well-lit room you should have. And we should have adequate exposure, proper exposure.
We should, in any case of neck swellings, at least from the entire face up to the mid-chest, it can be exposed.
Okay. Exposure should be there, sir. And also,
any female patient you are examining, should have a chaperone, male or a nurse or a female chaperone.
should be there.
Good. These are the prerequisites. Then the comfortable position, preferably patient sitting.
And usually we start with the neck to toe examination.
Any physical examination, first thing is general survey, in which we do the head to toe examination. Before which, it's always better to tell the patient's condition to your examiner. Under what condition? Because patient examiner may not come bedside. He may be sitting. So, in the beginning, you elaborate under what conditions patient was there when examined. So, what do you start?
Yeah, for example, these patients are that comfortable, like they are operated and they are well oriented to time, place, purpose.
So, here is a middle-aged lady who is conscious, who is well oriented to time, place, and person, and was cooperative. If the patient was not cooperative, you do not can't do the examination wrong. If the patient is having myxomatosperma, we can't. So, similarly, if the patient is not oriented, okay. So, because these are all relevant to the thyroid case. Because in thyroid, orientation is important. What intelligence is important. Is having low IQ. Low intelligence means what we in fact he has a hypothyroid and there is a dipthyroid. It and everything is important. Okay. So we'll start like that. After that, my main things are about the nutrition and nutrition. How do you assess that?
Based on the musculoskeletal framework and also PMA of the patient,
you have to check
the height
and weight on the patient.
And we get clues. Yes, sir. Usually in case of thyrotoxic patient, they be thin build. But as
and the underweight.
Underweight.
And yes, despite having good appetite, they'll be losing weight.
Whereas in case of hypothyroid patient, they'll be obese. Despite of poor appetite, weight gains. And also general condition from head to toe. We should also check for the scalp head and also lateral.
What will happen in hypothyroidism? There will be
loss of
diffuse carefall will be
there. Then and also one more important thing is the lateral 1/3 of the eyebrows. There will be in case of hypothyroidism there will be loss of lateral 1/3 of the eyebrows, which is called as medarosis. Then we looked at the faces.
Face is very important. If you leave up through, you're looking at the face only, we can tell you. But so the patient is having
whether hyper or hypothyroidism. In case of hyperthyroid patient, he will have a
shuffle. Look at this lady, that face, and look at that lady. Not a difference is there in the case. Here the lady looks like stary looking. Okay. So whereas patient there is almost like a very expressionless, mask-like faces like this. So one patient is thyrotoxic, another is hypothyroid. But you're just looking at the face, a puffy face up with a expressionless, mask-like hypothyroid. But a patient is having starry look like this, very anxious. Okay, that is
the hyperthyroid. Then also the examination of the oral cavity is very important. Actually, 3 things we should check. One is the tongue fasciculations, which is seen in case of thyrotoxicosis. Here we should ask the patient to open the mouth and place the tongue in the resting position. and you should check for approximately demonstrate. ಒಮ್ಮೆ ಬಾಯಿ ಓಪನ್ ಮಾಡಿ ನಾಳೆಗೆ ಆಗಿ ನಾಳೆಗೆ ನಾರ್ಮಲ್ ಜಿ ಬಿ
like this in the resting state, not protruding out. Okay, in the resting state, that for 30 to 30 seconds to 1 minute. If there is any 5 tremors or pitching, stitching in the answer and tongue fasciculation, the answer is to thyroid.
And one more thing is macroglossia. Very good. You should also check for macroglossia. In case of hyperthyroidism, there will be macroglossia. One more is liquid thyroid. Yeah.
Ectopic or limbal thyroid.
Ectopic or liquid thyroid, we should see. So these are 3 ticks in the oral tab.
Yeah. I know. Bye, Richard.
Bye. Then you should examine the upper lip. Upper lip is also very important. So because 3 things we can infer here. One is fine tremors. In case of thyrotoxicosis, the patients will have fine tremors. Just again.
In that, your paper share, yeah. So, Ram, he might get my correct way. And look tangentially like this. Okay. So, see, there is any tremors are there, and if there is tremors are there, paper will even fall off. The worst tremors are there, will be evident like this only. But for very fine tremors, you keep this paper. So that it falls off, then you just pick. And what else?
Support thing is very important. That is, we should the feel for the palm. In case of thyrotoxic,
There is really looking, touching the patient only with the pulse.
Yes,
With the hands are very warm and moist or wet. That is thyrotoxic also. If the patient is very dry, inelastic, that is hypothyroid. Very good. I suspect. Then the third thing, what is that?
calling pulse we should check. Because in case of hyperthyroidism, there will be tachycardia. And it is also graded according to price classification.
Ectopic beats can be where of arrhythmias are common. Usually, usually since AP nose. And then you continue to do the other exam, chest, abdomen.
Logics, they should do pedal edema.
Pre-tibal mix.
Edema. In case of hypothyroidism, those will be present.
And everything is thyroid acropathy cancer. So entire head-to-toe examination is thyroid dermopathy, skin changes, snail changes, everything you have to submit in the head-to-toe exam, head-to-toe exam. After which we go to local examination. Yes. So how do you start local examination?
So local examination of the neck. We'll ask the patient to slightly extend the head, sir. Okay. Slightly extend. And in case of obese individuals with short neck, we perform a special maneuver for this Bezillos method. But in this case, it is not needed.
The shortness of with the obese period, it is when the swelling is not very prominent, but can't see clearly. Then how you do?
You ask the patient to clap their hand and keep it on the occiputor. That we ask the patient to apply pressure over it so that swelling will become more prominent.
But in normal patients, you just do under normal
neck. Correct. Thank you. Correct. Then on inspection, we look for 30 things we look.
Very good. Always, I teach my students to remember everything by numbers so that you will not miss out anything, you will not forget us. Like Dr. was mentioning, in the oral cavity 3 things, in the upper limb 3 things, in the inspection 13 things, like that in palpation 13 things. There are things, if you remember by numbers, you will not miss out anything. It's very big. This go at the systematic focus.
Inspection first, like any swelling, number of swelling.
Whether solitary swelling or multiple swelling.
Whether it is solitary or multiple.
How do you do? How do you please demonstrate inspection? So you stand in front of the patient.
On right side I stand and I'll just look the neck. So here there is just the coronary midline neck swelling is the apex. And
other there is number. What is the number? And there 5S. 5S mean what is those?
One is
thyroid is in front of the neck. And then size of the thyroid. Approximately on inspection, it appears to be how much? Maybe 4 into 4 centimeter. Okay, approximately 4 into 4 centimeter.
Then very shape.
If it is either spherical or globular, if you can see the depth, then 3-dimensional. It's globular. 2-dimensional, you can be spherical cell. Well, then side shape. Higher surface of the swelling, over the swelling. There is a very smooth surface or the nodular surface or oscillated surface. Here see, it is very smooth in colloid goiters or primary thyrotoxicosis, like in graves and all, you get smooth surface. Whereas in multinodular goiter, there will be nodular goiter. In anaplastic carcinoma and all, you get bosselated surgeries. So then
also skin over the spell.
in or the spell is well, like there any APS casimas, any erythema, or okay, any dilated veins. So then
And after that, we'll comment on the extent of the swelling, sir. From the bony landmarks, sir, he'll comment on the extent of the swelling. For example, above from the chin and below of the suprasternal lawns, where the is situated. And one more thing is margin of the swelling.
very
This is some thyroid. Why? Because especially the lower margin is very important. If the lower margin is visible, then it means that there is no retrosternal extension. Whereas in case of retrosternal goiter, the lower margin cannot be visible.
So let the lateral margin, there is a as lateral margins maybe many a times it's the very last fillet, it will be under the thyroid. You can't really make out. Okay, so only upper border may be well defined, lower margin may be well defined sometimes, and lateral borders. If it is small filets, you can make out. So the large filets, we cannot comment about the lateral margins of the fillet. If how many points over? 8 points. So then,
And other two important things is movement with the deglutition and movement with protrusion of the tonsil.
so the classic picture of the thyroid or solid. How do you do that? Please about.
We'll ask the patient to swallow lateral. We'll ask her to swallow or what saliva, or we can give some sips of water. So, in Mugulan, just nunga. So we can note the movement of the thyroid gland, upward movement of the thyroid gland with
The pinch swallows, the swelling is moving upwards. Okay, that suggests your this is thyroid very well. Having said that, there are some other swellings also, so it can goes with like evolution. You should know what why swellings are. That's
then, and one more thing is the movement with protrusion of the tongue. So usually thyroid is moves with both the deglutition as well as protrusion of the tongue. Whereas thyroid cell
out to that. You might not. When she protrudes the tongue out, the saliva will move because thyroid duct arises from the fluorescent peak of membrane. When the tongue moves outward, swelling goes.
But in this case, this movement is noisy because it is a thyroid cell form. And
10 points or 3 points.
And other thing, sir, you look for any like pulsations.
Visible pulsations, hieronyphosis of high vascularity, visible pulsations can be there, sir.
And one more thing, any other swellings in the neck also we'll see. Like any others.
Like what if there is some lateral, there is another swelling is see. What do you if
I usually lack a aberrant thyroid, we tell.
See, affect lymph flow. So your lateral aberrant thyroid also lymph cake. Then what else work is to check for the neck. Other than the thyroid, other than cervical lymph nodes, what else you want to comment? There's in case of one huge goiter.
If there is any dilated veins,
What about the position of trachea?
Position of trachea. That also we can measure inspection. That is a sign called as trial sign. Whenever the trachea is divided, in the case of large thyroid swelling, as the trachea is divided to the opposite side, the sternocleidomastoid mass at head will be prominent. This is called as trial side.
See, for example, my left thyroid, there's a each swelling goiter. It pushes the trachea to the right side. So what happens? Immediately my sternocleidomastoid is stretched. So the sternocleidomastoid hand on the sternocleidomastoid lizard epicles more prominent. So portrayal side. By inspection only, this prominence, undue prominence of this end is there. So this is your duration after the rear. These are the 13 points basically in inspection. Next coming to the palpation. How do you start the palpation? In palpation, again, make sure that you extend everything irritation. I'm going to touch your thyroid gland. If you are having any pain or if you are having any discomfort, please let go. I'm going to do this test. We should explain that before. Then,
so first, as in any other swelling, we start with whether there is local as of temperature.
There are 3 ways. There are 3 ways of doing palpation. Usually, normally, we stand behind the patient, and us slightly flex the leg. Why? Because to relax the staph muscles and the fascia. Okay. Then your thumb should be over the occiput and other 4 fingers in front of the neck like this. We start palpation. Okay. This is the normal way. Not okay. Sometimes if you feel there's a nodules present in the lateral aspect of the lateral, posterior lateral aspect of the thyroid, then what we do, we come in front of the basis, and it's called Lahaye's method. Can you please demonstrate Lahaye's method?
For Lahaye's method, we stand in front of,
For example, if you want to look for right posterior lateral,
then with our left hand, we'll push the line towards the right side. And with our right hand, we'll palpate for the posterior lateral.
I'll demonstrate same from behind. Okay, if I want to take here posterior lats and push the left lobe so that my right lobe becomes more prominent, then I feel for posterior lat. It's Lahaye's. And if you're suspecting that small nodules, then there is something called the Trice method. And how do you do that?
Here we stand in front of the base, and we'll place the thumb over the thyroid sphere.
What that nodule, so better nodules like the nodule.
And we'll have to place into swallow among this. So we can pick.
Yes, on the aspect of a swelling, or nodule we can make out what the approximate size, its shades. So these are the three ways. He says this is a comparatively large swellings. We can do a normal examination by standing behind. In a bit, come behind and start doing the examination. Like first you confirm all your inspectory primary why you did like a number or palpate the entire plant and feel how many nodules are there. Okay, now how many nodules are there here? Like here, feel for the entire eye. See my multiple or like one single one second. So literally no, you got it. Then come to the side. Where's side? Exact in the eye, midline.
Midline.
We back up then the side. Size across now we measure. Is using measuring direct measure bed then one vertical here and even the depth 3-dimensional image. Okay, and then is a globular or what?
Then and also I went for the surface. How I can confirm whether it is
what is surface here?
So here it actually appears to be in this here smooth.
Suppose so. Mostly it's a poloid goil or maybe there's a features of thyroid. Suppose it to be grayish. Very. Then also consistency also. Yeah, then make what we didn't do in inspection or we are going to do in palpation. We see what it is consistency.
Consistency can be soft, hard, or it can be stony hard or very hard. Like in this case, it appears to be the softest.
This poloid thyroid, but some cystic content is there. Could be soft in consistency. Second, normal thyroid is pomic consistence. See, okay. Whereas in or some malignancy and all may have we hard part in anaplastic and all it to be stony hard stony sorry. Having said that, in thyroid there is something called thyroid paradox. Okay, that means even the benign swelling can be hard. Okay, whereas the malignant can be okay, and even the because of dense colloid or dense cyst inside, it may affect as firm, but still is benign, unlike other swellings. That's usually hard means we consider it to be malignant. But in the malignant swelling in thyroid, because of the necrosis or because of hemorrhage, it to be pent as a soft or cystic disc. Okay, understood, no? Thyroid paradox. Then also the part of peel, no palpate as that the posterior margins are these things. That it is lower margins. How do you say for lower margins? Keep your heavy fingers in the underneath the upper lip, in the supraclavicular process. And are some patients who patient alkali.
So it is the swelling moves up.
Yeah.
And you know this? Okay. So if you are able to keep and the swelling moves up, then there is no recursional extension. Very. And also margins will look whether they are well defined or ill defined, or if they are well defined, they are either regular or irregular. We gonna check.
Then movement with deglutition, I can confirm with the palpation. Sometimes thyroid swellings will not move with deglutition. Can you give example?
So like if they are fixed, for example, in case of malignancy, one is anaplastic carcinoma, and sometimes we reverse thyroid
or any previous surgeries or any huge part, they will not move with very rational vertical case. So palpation you can confirm. Then what's important here is some signs, three tests are.
What are those? One is coccus, one is Pemberton, and another is very serious.
What are these characteristics? These are very important in exam point of view. Although clinically we don't
first demonstrate Pemberton site. Usually Pemberton sign is we usually do whenever there is a large goiter with retrosternal extension, suspect retrosternal extension. In these cases we do, but in this case I just demonstrate what. So we'll ask the patient to dip their voice in a mask. So the idea is keep it touch. He can just with a ear. And we ask for 30 set. Body look for patient congestion and dilated was.
What will happen? This rectosternal goiter, they will compress on the, and the inlet is becomes narrow. The it will come SVC, CV or jugular veins will be compressed. So, all the venous drainage is hampered. Venous facial congestion. It is a relative way.
You know, the neck. Oh, very. So the temperature side. And one more is focus test. So this
Why that?
purpose to Lola is whether there is any tracheal compression.
Where tracheal compression in case of very benign cells can cause tracheal compression.
Benign, it is very huge. It can
Long stand on voice in under quarters hell slowly. What can cause friction over the section because of that compression capacity. Okay. Then malignancy can
malignancy also can. So for Docker's test, we just put the pressure over the lateral aspect of the thyroid gland, and we'll ask the patients to be here for the breathing. Whenever there is answer compression of the trachea, we can hear stridor. So stridor can be.
remember this. Stridor is because of the compressed trachea, whereas hoarseness of voice is because of
Involvement of the
Under the opposite difference between hoarseness and stridor. Stridor is brachial compression. Whereas recurrent irregular compression will lead to hoarseness of voice. Okay? So this is the copper state. Just press the lateral aspects of the lobes against the trachea gently and listen carefully. The patient develops stridor. That means that case some tracheomalacia has happened. Malacia's leak because of the long-standing erosion of the trachea. It's getting compressed easily. Should be very, very careful. And you confirm it by taking a lateral X-ray. This tracheomalacia should be seen as a interpostal compression for the scabbard trachea. You keep your alvar to scabbard.
And the last one is Berry's sign. So Berry's sign, there are two scenarios. In case of large benign swelling, the carotid pulsation will be displaced from its normal position. It is pushed backward. It is posteriorly displaced. Whereas in case of malignant swellings, they will engulf the carotid mesh. So the carotid pulses, you could not able to feel. It will disappear. So usually the carotid pulses are tight at the level of the thyroid cartilage. Like in the anterior border of the sternocleidomastoid muscle, we tell the pulses of the 6th thyroid versicolus to the this tubercle. So we peel for the carotid pulse. So we should peel only on one side, not bilateral by another. Not shoots. So when you feel for carotid pulse, so this is killed
the normal position and right. If it's not, if you can't kill there, then what you will do?
like posteriorly.
Is it huge jobs? There also it is not peltils. It is engulfed with ostin malignancy, which is engulfing the carotid sheath. These are three things. Then again you palpate the after all the tests done, then what you do? Lymph node examination. How do you do? All the 7 levels of lymph nodes or cervical lymph nodes. What are those? Now with these 3 fingers, middle 3 fingers with the pulp of these 3 fingers who start submental. Okay, 1A. 1V is submandibular. Next 2, 3, 4 along the jugular vein. The anterior border of sternocleidomastoid, upper jugular, mid jugular, lower jugular. Okay, upper 2, 3, 4. And 5 is posterior triangularis behind the sternocleidomastoid pies. 6th is pre and paratracheal central compartment. Pretracheal like this and paratracheal. 7th is the arastub, media stub. So the 7 levels of lymph nodes you have to check them.
And also, we can also the position of the trachea. They can also pagaricorm with palpation. We can use 3 fingers. That 2 fingers to stabilize the trachea, and we can feel for the trachea type of stabilizing it with 2 fingers. This is also like weird sign of palpation.
Okay. Then take in palpation.
We can also need to there is any to do
relate the hyperthyroid or thyroid or hyperdynamic circulation. Hyperdynamic get peak. Feel for the 3 per 4. Yeah, good. Very. 3. Then percussion. Percussion mileage not as important, but in further so the malabik karne. If it is in a dull load, if you usually get lateral aspect, you get a resonant. If it's dull, that means that extension was or maybe the lip. Then the auscultation. Auscultation you mainly check for groovy and the upper cope. Okay, keep your stethoscope in the upper pole of thyroid. Why upper pole? Why not lower pole?
Because superior thyroid artery.
So it's very superficial and it's straight and fixed course, unlike inferior thyroid. Check for any sound because of the hyperdynamic
Dynamic circulation.
if is the issue shows. Tell up that all the four things that what you
Then the eyesight says eyesight is very
then where for example this lady is thyrotoxic. Can you please demonstrate eye sense here?
so she has a starry look. She has with the slight protrusion of the eyes.
See, there are four types of eye sacs, right? Main. First thing is, and first form which formally occurs lid retraction. Lid retraction is the first side. Then comes the
Lid black.
or because of the
That mullus muscle. Levator palcadry. Immolis cosmet.
that is lid retraction tracks. All these are because of the exophthalm, right? So there are some four signs. So one grape is
Bad lid bulb say. Then obvious say. Chopra is saying. Stelwack.
this is the first one to come. In the mild, you can grade the exophthalmos also. Mild, moderate, severe. In mild, you with SVD. What is that SVD?
Skelvator. One rapid and dark with pearl.
All this is because of one cause. What is that? Hyperactivity. Hyperactivity of the bullous or superior or auricularis muscle overactivity, contraction. SVD. Okay, then you get in the moderate, you get because of the deposition in the retroorbital space. So there are prop tops this be not absorption, exop. These two things different. Okay, exophthalmos because of the deposition in the retroorbital space. Okay, what are those tests?
So from that telecast I see the
Chappers. Then in the superior, in the intraocular muscles also get deposition, intracellular deposition of the matter. Then there will be one more chance on the eye boa. Oh, that's called Mbbs. And even the data state, then there will be ophthalmoplegia. Means the third type of eye sign. First is lid up. You have to know the difference between lid retraction and lid lag. Lid retraction is different. Lid lag is different. So lid retraction first. Second is the because of the bullous muscles muscle exophthalmos. So this is lid retraction is bullous muscle cell exophthalmos because of the deposition
of the retroorbital ocular space.
Okay. Then third thing is ophthalmoplegia because of the weakness of the muscle. Which are the muscles? Superior rectus, lateral langus, inferior oblique. Because on patient will have hand no upwards and lateral. The fourth one is on the last stage because of severe edema in the lymphatics and venous congestion will be there. Result chemos. These are the four eye signs. What do you demonstrate? First thing, suppose lid lag. You stand in front of the patient and look at the levels of the upper eyes. One eyelid is above the other, there is lid retraction. Eye retraction is okay.
And for lip platter,
I can take after lid retraction, then you come to lid lag. It's one great case that is I. What do you do now?
We usually ask we should tell the patient to point our finger, and we should ask the patient to follow the finger. And among the contain no or not the
face should have been see face be firm. Male nodi. Usually see and repeatedly you do like this. Okay, and once you can feel that there is a lag in the looking downwards. What they can remember downwards, even then sclera will be I said that this upper eyelid will not be moving fully downwards. So the little lag, okay, that's the lid lag. One grape is
then Stelwack said is starry look very must say first
Stelwack. Then the wrong way. Stelwack infrequent bleaky. White is at a eraser. Okay, like this. The question is like this. Infrequent sheets but doesn't blink so frequently and eyes are wide open. So this is Stelwack like cell. One way is the tail ripples.
And is it detections. The upper sera will be
visible. Usually the upper part of the athada will be closed, covered by the lip. If it is visible means then the detection is tail ripples, ripples. And in the moderate to get
bonded we get
job price.
Job price saying is you should ask the patient to look upwards the neutral position It's ask the patient to look upwards. Hello.
Melody, kannalli mel.
Antani pene.
Usually we get details.
It is case like make pain, but no wrinkles below it is. So it is then job price side is positive.
Then the last one is Mbbs. Mbbs sign is order convergence. Mbbs. And how do you check for her exophthalmos?
It's not single
sites. Okay. So we now
stand behind the patient, right?
you got the supraorbital that supraciliary notch is the which is there. You have to check. The eyeball is in front of that. You can able to do an exophthalm. So how do you distinguish between proptosis and exophthalms? Okay. And there's another test. What is it? In case of exophthalm proptosis, you can avoid the upper iris. Whereas in exophthalmos, because of what contracted cannot really retract the upper iris. This is how you distinguish between proptosis and exophthalm. Okay, so and other all the eye signs are there are so many tests are there, but this is enough. This by test fight more than is important. And how to demonstrate your lack of anything else? Systemic exam. Thyroid is done. Thyroid and all eye signs you demonstrate. Systemic examination very important. And step for the cardiovascular system.
Usually in primary thyrotoxicosis, still level system will be affected.
Especially you should check for certain levels of the system. You should check for all these reflexes. Paralysis checks. They per exaggerate or
rather it is and case of secondary thyrotoxicosis, cardiovascular system will be affected. The patient will complain of chest pain, palpitation, shortness of breath, and this is patient will come patient will complain. So these things you should check as such.
And then the other thing, the upper abdomen check the muscular skin cell chest, and then if you suspect to be malignant thing for any years of malignant lesions, neck you already lymph nodes or does before hematogenesis spreads to the flat bones or long bones. Because only when the stage I beg you all. What are those process for both space of voice in case of thyroid?
Process of voice because of mainly involvement of infiltration of the recurrent laryngeal nerve, sir. One more is because of compression. The last hypothyroid. Hypothyroid to make sense. Local edema, autopod edema, there will be palpitations of course is something.
What are the core causes of dyspnea in thyroid? What are the core causes of pain? What are the true causes for both space and voice? Like this, you should learn. Okay. These are theory aspects you should learn. We have so many videos on that, wherein we have in detail we have discussed the process for each thing. Hope you understood all about the examination, and I meant very easy. You remember with the help of numbers. First, how many things to look for each things. At these special tests also we have learned. At the end, we have made a provisional diagnosis by the consistency, by the one thing. What we missed is two things. What we missed is one is plane of the skull, and second is mobility of the skull. Mobility, there is horizontal line, vertical mobility is there also. Plane of the skull by contracting the fascia. Whether it becomes more prominent or less prominent, we can say this is deep to deep fascia, so it becomes less prominent on contraction of the neck. Is shitting some sort strong. Okay. Thank you, Ma. Thank you.